It's absolutely changed drastically. The biggest change that we have seen is the advancement of what's called endovascular procedures. Procedures that use balloons and stents to improve the blood flow. 10 years ago, we had balloons. Then we moved into the evolution of stents. Now we have balloons and stents that are coated with medication to help increase the longevity of those interventions. And soon we'll have stents that are absorbable. So they get put in with a drug on them, and not only does the stent go away, or the medicine go away, but then the stent would go away too. The area, however, where we are lacking is preventative medicine. So preventing these patients from even getting to this level. Statin medications, controlling blood pressure, new medications that control hemoglobin A1C and blood sugars in patients with diabetes have all made a huge change. And just paying attention a little bit more to that for every single patient. For some patients, there's still access problems. Getting to a primary care physician or getting to an early referral endocrinologist when you have diabetes, or getting to somebody that understands peripheral artery disease and can continue to make sure you're taking your medications. What a lot of patients don't understand is these medications are now generic, and you can get a statin prescription for 90 days for as little as $9. And that's something that we need to continue to promote. Patients say, well, my medications are so expensive. Providers should understand this, and most of them do, that we can change your medication. We can put you on something to where the most you may pay a month for 3 different medications is $36. An aspirin is even cheaper than that. So for a bottle of aspirin, and most patients only need to take an 81 milligram aspirin, that'll cost you somewhere around $2 to $3 if you buy generic. The next 10 to 15 years is really about getting the patients in the preventative phase. So talking more about putting them on medications that will prevent plaque from developing, learning how to create a medication that dissolves plaque. That is something that we don't do very well. We haven't come up with those medications. In patients that have diabetes and even renal failure, learning how to control their electrolytes better so that phosphorus binders or calcium binders are able to prevent hardening of the arteries or calcification. That is where I really see us moving. Gene therapy for different patients, precision medicine to know that this patient is able to create such calcified plaque that they are not going to respond well to one medication, but they need a different type of medication. This patient doesn't necessarily develop the hardening of the arteries in the same way. So knowing who needs what therapy, that's the next 20 years of medicine across many different fields. Especially in diabetes, where you have patients where they're taking oral medications for diabetes, but then they're still not getting their blood sugar controlled, and then they're put on insulin. Figuring out what medications can be used to treat those patients with an oral form rather than just insulin is really where we're going in the future. The military systems are so important. The nice thing about UC Davis is we have a alliance with David Grant Medical Center here. And that facility actually does a lot of our arterial work. They have a small and large animal model where they are looking at different shunts or different balloons that can be used to improve blood flow or changes in blood flow in that way. So our alliance with the military is absolutely necessary for us to continue to do what we do. In addition, we have trainees that are going to be going out into the field with the military, vascular surgery trainees that we train both at UC Davis and at David Grant, and they continue to bring the academic medical center thought process from how we treat critical limb ischemia into the treatment of people out in the field. So how do you take somebody who's just been shot in a war zone and use the shunts or the techniques that we have to then save those patients? One of the things that we're working on is a stent that can be deployed in the field It's actually a covered stent, and it acts like a shunt. So if a person is shot in the leg, in an extremity area, or in the arm, you could place this shunt, and then it would direct blood flow from the artery above and below the injury. And a lot of that comes from using these particular techniques and these stents on a daily basis in our critical and acute limb ischemia patients, so that now we can take that and bring that out to something that can save lives in the field, especially for the young soldiers who are risking their lives.